I would like to thank Iraqi Hypertensive Society for their kind invitation to be with my colleagues to share knowledge for this beautiful day. So it's my great pleasure to present this very important, unfortunately neglected topics in many guidelines. And this is in postmenopausal women. I searched many guidelines. I tried to find any information for postmenopausal women. This term, unfortunately, I fed up. So this is the outline, an included case study. And why we should focus today on postmenopausal women? Because according to the WHO, as our colleague mentions, 2020, up to 40% of Iraqi people, unfortunately, who are more than 25 years, have hypertension. And they reported that there was higher prevalence rate of hypertension in women. Unfortunately, the death rate in Iraq, WHO. Unfortunately, our ranks is 101, and the death rate reached 16.27 per 100,000. So it's a terrifying figure. Hypertension in women in younger ages is easily controlled. My colleagues mentioned about eclampsia and preeclampsia, but unfortunately, once the women get older, the control rate will be very difficult and lower as compared to men. So the other problem, that's elderly women are expected to have more severe hypertension and lower blood pressure control versus middle age and young women. Each year, 55,000 more women have stroke than women. Each year, twice as many women die from stroke as from breast cancer, and still we are neglecting postmenopausal women. Well, what is the postmenopausal woman? So simply, that is occur years after a person's last period. It's considered postmenopausal. Our Ministry of Health in Iraq statistics showing in 2006 STEPS study, a survey conducted in Iraq on chronic non-communicable disease, found the prevalence rate of 40.4%. And the WHO also reporting 29.4%. Many studies done by our expert colleagues in different areas in Iraq. Because of the shortage of time, I will focus on Nasiriyah city and Erbil city. This is a household survey, more than 1,400 patients, and the prevalence rates unfortunately reaching 26.5. And as you can see here, the difference between women and men is fluctuating, but as we're reaching the age of 45 to 54, women exceed men. But after that, start to decline. Other studies done in Erbil, unfortunately, the prevalence rates reached twice as in the Qar. And again, there is increasing prevalence rate with age, but I couldn't detect, unfortunately, the difference between male and female, especially in postmenopausal women. What about the United States? Also, the women, as age more than 60 to 40, exceed the prevalence of men. And this is figure reported by many colleagues and confirmed that higher blood pressure is the leading risk of death as compared with any other risk factors in both gender, also in women. What could be the explanation for postmenopausal? Could be genetic predisposition, obesity, aging, decreased estrogen testosterone ratio, other factors. My colleagues today give us good information about preeclampsia, eclampsia, gestational hypertension. But the important point that this point we don't know whether it's precede to postmenopausal hypertension. We need large randomized clinical trials. Again, the primary prevention is very important to start as early as possible. Medical issue, non-steroidal, cortisone, metabolic syndrome, and pregnancy should be checked. So these are the mechanisms for the rise of blood pressure. That increased androgen level lead to activation of RAS system, high renin level, increased plasma endothelin level, high salt sensitivity, increase in weight. So I will start with this case. This 64-year-old household consult me because of rising of blood pressure over the last 3-4 weeks. Before 1 month, she was well controlled on amlodipine. And this patient is overweight, normal renal function, borderline hemoglobin A1C, with high total cholesterol reaching 225, the LDL of 120, borderline hemoglobin A1C, with an ejection fraction, good ejection fraction, mild LVH, and mild left ventricular diastolic dysfunction, and we couldn't detect any evidence of dyspnea or chest pain, ECG, sinus rhythm. With her blood pressure reaching uncontrolled, and her blood pressure reaching 180/90. The patient was very obsessive about her lifestyle and her medication. She was on amlodipine. She asked me why my blood pressure shoot up. So what could be the risk for these patients? This is mild, moderate, severe. In addition to lifestyle, which antihypertensive shall I choose? Amlodipine, calcium channel blocker, diuretic? And what's the target of blood pressure? I tried to search in the guideline, but still I couldn't detect any real answer apart of trials. So how to treat? So I should consider the risk factors, that is obesity, metabolic syndrome, previous polycystic ovary syndrome. Lifestyle is very important, keeping in mind that hormonal therapy, menopausal hormonal therapy, is limited because it is contraindicated in high-risk patients. And most of those elderly patients with hypertension, unfortunately, presented with a lot of risk factors that we couldn't. So we have only antihypertensive patients to help the patient. Trials, what is the trials difference from men and women? Dash trial equal in men and women and get some benefit. So dash trial, dietary approach to stop hypertension is a good for these patients. What about the treatment threshold, blood pressure target, types of antihypertensive medication? The blood pressure threshold for initiating drug treatments, blood goal, which drugs and drugs combination are most effective to reduce cardiovascular outcome, unfortunately, are not conclusive. ACC/AAR 2017 hypertension guideline note, there is no evidence that these issues differ women versus men. And what is the benefit of earlier reduction of blood pressure? It is reasonable to assume that earlier blood pressure definitely will reduce the risk of stroke, heart failure, diabetes, and what's important, the cognitive impairment in menopausal women. Which drug I should choose? Some trials, some studies found thiazide diuretic is beneficial for postmenopausal. They decrease calcium excretion and probably may decrease the risk of a fracture. Women frequently experience edema with calcium channel blocker. One of our colleagues asking a question about amlodipine. Some studies confirm that. And angiotensin converting enzyme carry a lot of side effects, especially cough. Hyponatremia, hypokalemia, and studies reported more frequently in women as compared with men. So these are the trials, DASH trials, losartan effects. There is no benefit, there is equal benefit in men and women, and a comparison of outcome with angiotensin converting found that AC inhibitor is more effective in men as compared with women. Supplementary trials also showing that among patients at high risk for cardiovascular events but without diabetes, targeting a systolic blood pressure less than 120 as compared with less than 140 result in lower rates of fatal and non-fatal major cardiovascular event and death from any cause. My colleagues Saad Al-Badri reported that we should not be cautious in very elderly or elderly to afraid to stop hypertension or to decrease the level of hypertension. Most of the patients, well, I have low blood pressure, I am 70 years, I am 60, so 160 over 90 is accepted for my age. The same as 40 years, so this is not more recommended. So these are the risk factors, should be cautious to use. And hormonal therapy, the drug adherence also is very important. The risk factor is very high, and we should, according to spread the trial, lower the blood pressure to less than 120 over 80. And this is the guideline showing in our patients with the blood pressure more than 160, so should be promptly treated with 2 antihypertensive medication. If controlled, check whether it is resistant or not, as my colleague mentions, and to follow the patients and adhesion. Pay attention to orthostatic hypotension and the other side effects. Put in mind to prescribe 1 pill, 2 pills, and to proceed, follow up the patients, and at the end, so more large randomized studies on the prevalence and the control rate of postmenopausal hypertension is recommended. Blood pressure targets have not been established by the highest level of evidence, particularly for older women. Many knowledge gaps persist. For example, the contribution of hypertension disorder of a pregnancy to future cardiovascular disease in women, and optimal blood pressure targets for the elderly. Thanks a lot.